Okay, so we'll get started for this week. Thank you all for joining us to the Miami Global Brain Tumor Symposium. Just a couple of short introductions before we get started with tonight's special guest. My name is Michael Ivan. I'm one of the brain tumor and skull-based specialists here at the University of Miami and director of our research program for brain tumors. I'm joined tonight by my co-directors, Dr. Morcos, who's the professor and co-chairman of our department here at University of Miami. He's also the director of our skull-based and cerebrovascular program. Dr. Komatar, who is a professor and program director of our residency program, also director of the UMBTI and surgical neuro-oncology, and Dr. Benjamin, who's our newest recruit, assistant professor of brain tumor and skull-based specialist, and director of our Kane's Neuroanatomy Lab. Can't do this symposium every week without the help of our great administration. We have support of the Cancer Center, the university, Christina, Ingrid, Roberto, and Ignacio. Thank you so much for all the hours that you put into making this such a success for the last 16 weeks. If anybody wants to find out more about either our department or our symposiums, we are on social media. You can follow us on Twitter, YouTube, Instagram, or you can visit our website here at neurosurgery.med.miami.edu to find out about future symposiums for both myself, the brain tumor program, the skull-based program, and our residents. Quick teaser, on Thursday nights, we run a very similar symposium with cerebrovascular and skull-based focus. Tomorrow's night, at the same time at 5 p.m., we'll be having a debate looking at carotid endarterectomy techniques with Dr. Wilson and Dr. Harbaugh, so please be sure to tune into that. Also, a quick teaser for next week, we'll be joining Dr. Teo, will be joining us talking about keyhole surgery for gliomas. Will be joining us from Australia. Be sure to tune in for what should be a great talk next Wednesday at the same time. So quick housekeeping for participants, please, we try to make this as interactive as possible. Use the Q&A button to ask your questions. Both myself, the directors, and panelists will try to get to them throughout the talk, and also ask Dr. Carter at the end. We don't offer any CME or certifications, but you will get an email confirmation documenting your participation. And please be sure to like, follow, and share our videos on Instagram, Twitter, and YouTube. And if you have any ideas for the upcoming symposiums, please be sure to share those ideas with us. So let's get to this week. We have a great set of panelists, all coincidentally located in New York City, but phenomenal nonetheless. Dr. Oranger, associate professor at NYU. He's in the Department of Neurosurgery and Pathology, and a key component of their brain and tumor center. And he's a brain tumor specialist. Dr. Agarwal, assistant professor and director of the Skull-Based Center at Albert Einstein, also in New York City, brain tumor, skull-based, and vascular specialist. Is also the assistant program director there. And Randy D'Amico, who's now on the famous Lenox Hill program. If you've missed it, please check it out. He's director of neurosurgery at Wyckoff Heights Medical Center and a part of the Northwell Health System brain tumor and skull-based specialist. And of course, tonight we have a very, very special guest. Dr. Carter really is a great mentor and leader in neurosurgery to many of us, including me, really the epitome of a physician scientist. He's a neurosurgeon specializing in complex brain tumor, skull-based, and vascular pathology. He's the chair of the Department of Neurosurgery at Mass General and the William and Elizabeth Sweet Professor of Neurosurgery at Harvard Medical School, where he leads the brain tumor program. And he joined that department after leading a really successful program at UC San Diego for more than 15 years, where he's had also many, many acclamations occur. Even more impressive, he's NIH funded for over 20 years, where he devotes his research to promoting neurosurgery's use of tools and diagnostics, many of which we'll hear tonight. Some of that includes leading the first reported EGFR-V3 directed CAR T-cell therapy, and some of the first work that really describes exosomes for glioblastoma patients in liquid biopsy, which is exciting information that I'm sure we're going to hear more about. Obviously, he's extensively published and traveled, lectured around the world. Also on the board of Journal of Neurosurgery and editorial advisory board of neurosurgery. So extremely busy, and I just want to thank him so much for taking out the time to talk to us all tonight and educate us on a very, very exciting topic, which is really what the future of neurosurgery will be. Dr. Carter, thank you so much.
Great. Happy to jump in. And do you have my screen out there, Michael?
No, if you could just share it again, that'd be great.
Okay, let's do that. And here we go. How's that?
Looks good. Thank you.
Good, thank you so much. So thank you to Dr. Ivan and the rest of the University of Miami team for fostering this incredible global community of brain tumor specialists and those who are interested in brain tumor work. What a honor it is to be with you all. And I think we've all been so impressed by the leadership of Dr. Morcos and the rest of the group at Miami in brain tumor therapy. So it's a pleasure to be here. I hope tonight just to talk a little bit about personalized brain tumor diagnostics and therapy. Where are we in 2020? This is a very big topic. We'll be able to scratch the surface a bit, but I hope that it's of interest to those who are participating and listening tonight. So let's see here. And really appreciative also of my panelists, Drs. Oranger, D'Amico, and Agarwal, who are with us this evening. So I want to highlight a few different ideas. One is the concept of personalization in the context of low genomic complexity. I'm going to use craniopharyngioma as a case study in that. I'm also going to talk a little bit about targeted therapy for what we would consider a classically surgical disease, that's meningioma, with a little bit more complexity genomically. And then also how to consider personalized therapy in the context of a molecularly complex entity, which in this case would be GBM as our example, and some of the challenges and strategies there. And then also get into the diagnostics a bit as well. So I'll try to get through this in a relatively expedient fashion. Here's the general notion that by understanding better the molecular characteristics and features of a given patient, we can more appropriately direct a targeted therapy to their lesion instead of simply applying a similar therapy to an entire population. So what is it about brain tumors that make this a challenge, and what are the opportunities? So a first concept that I'm hoping to bring out is that single target therapies may make the most sense in tumors with low mutation rates and low molecular complexity. So here the case that I want to highlight is that of craniopharyngioma. We know that with genomic characterization of craniopharyngioma in the last several years, we've come to understand the canonical mutations that really drive this entity. And importantly, craniopharyngioma on the spectrum of tumors writ large, ranging from aggressive carcinomas to other types of tumors, it's relatively in the category of a low mutation rate. So these canonical mutations occur, but the driving to have many more mutations is less so than in other tumor types. Histologically, of course, we have our two classic types, the adamantonomatous and the papillary types, occurring in somewhat different age groups, and the histology being characteristic of these two types. And then the canonical mutations in beta-catenin for the adamantonomatous tumors, and then BRAF mutations for the papillary tumors. This renders a certain opportunity to us to think about targeted therapy, as we've understood that really these mutations sort out and are present in greater than 95% of these subclasses. Of course, BRAF has been targeted in other tumor types. There's a large pharmacology and associated industry behind BRAF and its associated downstream MEK pathway in terms of agents that have been developed and vetted in other tumor types. And there's actually been some successes, of course, in other cancers, including melanoma, with the caveat and the notation that sometimes early clinical resistance can develop as additional genetic mutations are acquired. A few years ago, some of the team here at Mass General, this was Dr. Priscilla Brastianos and some of my colleagues, Will Curry, Dan Cahill, Fred Barker, Pamela Jones, highlighted a case which I think opened the door for conceptualizing this low molecular complexity targeted therapy notion. And in this particular case, this was a patient who was in their 30s who had a multiply recurrent papillary craniopharyngioma. And you can kind of see through this course how dramatic this was. An initial resection at an outside hospital. Then within a few months after the initial resection, a recurrence with an emergency decompression, and then several repeat recurrences as this tumor rapidly regrew after multiple resections, including after initiation of additional therapy, such as radiation therapy. And so in this particular case, the patient was noted again as is typical of the papillary cases to have a BRAF V600E mutation. And so this patient went under a combination of BRAF and MEK inhibition. And this was the time course that was observed in this particular case report. And you can see that within just really a few weeks, there was dramatic shrinkage of both the solid component and the cystic component of the lesion, which opens up a new concept that either in the neoadjuvant setting or in the recurrent setting, such therapy could conceivably be applied. And interestingly, some of the histology on this particular case was quite fascinating. Pre-treatment, the classic features of a craniopharyngioma were noted, but post-treatment, the combination of fibrosis and substantial infiltration of macrophages really suggested that this was an important immune-promoting strategy for bringing this tumor under control. And again, on the follow-up resected tumor tissue, as this patient underwent treatment followed by, again, a more definitive resection, this infiltration of CD8-68 positive macrophages was noted, as well as CD4 and CD8 cells. Also, the patient's mutation was detectable in their blood pre-treatment, consistent with release of particles from the tumor and the ability to sample that blood. And in the post-treatment and post-operative sample, a normalization to nearly that of negative controls. So this we'll touch on a little bit later, but opens up the notion of liquid biopsy or liquid diagnostics, even in the histological sampling phase of this patient's course. And importantly, this patient, upon resection after initial treatment, this patient had the preservation of the one unique clonal event. In other words, this particular tumor type was not spinning off additional mutations to overcome this resistance in this particular patient. And since then, there have been a number of other case reports similar to this, highlighting different approaches with BRAF inhibitors for papillary craniopharyngioma. And this is another figure highlighting, again, similar shrinkage after a period of time of treatment, as is seen in this particular case. So in this context, Priscilla Brastianos, who's a neuro-oncologist here at Mass General, developed with the Alliance community the concept of a phase 2 trial of BRAF and MEK inhibition for papillary craniopharyngiomas. Here's the notion of the trial. A patient has measurable disease. It's been biopsy proven to be papillary craniopharyngioma. And then the patient goes on with a combination of either BRAF and MEK inhibition for 3 months of therapy. There are 2 cohorts. In the neoadjuvant cohort, patients are treated and they go on to definitive surgery and radiation. So this might be a larger tumor that one envisions shrinking down prior to surgical resection. Or in a recurrent cohort, and this would be cohort B, this would be a patient who had already had a surgical procedure, perhaps thought to be definitive, is now recurring. And so this is cohort A. Again, it's the newly diagnosed patients. This is an analysis of CNS response rate after 3 months. This cohort enrollment is complete. It was completed not very long ago, and analysis is underway. And I anticipate that you'll be able to read the results of this within the next few months as Dr. Brastianos gets this work written up. Cohort B is the recurrent patient, and again, same scenario, treatment. Patient can continue on treatment if there are no additional definitive surgical or radiation options available to the patient after the first 3 months of treatment. They can stay on the medical therapy. And this cohort is still enrolling. So if you have a difficult patient, and remember, there are only about 300 craniopharyngioma patients in the United States every year, but if you have a difficult patient, I'd be happy to put you in touch with Dr. Brastianos, for a patient with a recurrent tumor who might be a candidate for this trial. So this is kind of an exciting concept for a challenging tumor, the idea that we might be able to target canonical mutations in the context of low complexity. So let's stay tuned on that. Let me highlight now some notion of targeted therapy in the context of what we feel is a classically, really a surgical disease, and that's personalized medicine for meningioma. And of course, all of us have been involved with this work, and these are important tumors in the armamentarium of skull base and brain tumor surgeons in terms of the treatment modalities. These may also be suitable for targeted therapy, particularly in the context of relatively recent insights into genomic subclasses and an overall lower genomic complexity than other cancers. And again, as a surgical disease, I think we all enjoy operating and being involved with a patient who has a great outcome from a surgical case. But we know that even in the best of hands, recurrence is a real issue in terms of both benign grade 1 tumors, the atypical tumors, and of course the anaplastic tumors. And if you look at 5-year recurrence-free survival, in all of those, there are recurrences that do occur. This is a disease we've been treating for 100 years with surgery. Cushing gave this lecture in 1927, resection of olfactory meningiomas, and at his side, Louise Eisenhart, and her careful characterization of the pathology of these tumors has been something that we've relied on for many years. But we are also learning that certain genetic mutations have very strong predictive characteristics in terms of what patients are going to recur. So for example, in the rhabdoid meningiomas, BAP1 mutations are highly predictive, and the alteration in BAP1, if it's lost, portends a very poor prognosis in terms of recurrence. We also know that from the von Deimling group out of Germany, that TERT promoter mutations have a very strong correlation with risk of recurrence. So there's, beyond the histology, genetic information that's quite valuable here. Systemic therapy generally has not been particularly exciting. Applied to the entire group, we just see very low response rates. And this is a series of studies that was reviewed in a meta-analysis a few years ago, and very low response rates. But in that context, there really has been a genomic revolution in understanding meningioma. A number of papers from terrific groups highlighting perhaps quite specifically the Gunnell Laboratory out of Yale, Priscilla Brastianos, and some of the team here at Harvard Medical School, and others who've contributed to this ongoing understanding of what underlies the meningioma growth. And we've moved from our understanding that NF2 is a substantial contributor to at least half of the tumors to really seeing a fleshing out of all the different subclasses of meningioma types, TRAF signaling in combination with KLF4 or PI3 kinase, and smoothen for the anterior midline skull-based tumors, and then a number of other subclasses. Approximately 6 or so major classes of genetic mutation for meningioma. So how does this help us as surgeons? Well, in this context, again, thinking back to those difficult patients that recur, we do note that meningioma, again, falls into that category of a lower molecular complexity tumor, and therefore potentially the targeting of one or more of these mutations in combination would be of utility in this disease, particularly in the recurrent setting. And with this background, Priscilla, once again, one of our just superstar clinical trialists here, took 3 of these canonical mutations that have substantial industry support in terms of drugs that have been vetted, the NF2 subgroup, the smoothen subgroup, and the AKT subgroup. And using the alliance mechanism, we also launched a set of trials in these particular tumor types. And this is, again, Priscilla's efforts. One of the arms has been completed and was reported at ASCO this year. And that was a phase 2 trial of targeted therapy. And this was the NF2 group with FACT inhibition as the downstream mediator. So here's the kind of baseline. These are recurrent or progressive meningiomas. I'll show you a little bit about those criteria in just a moment. Characterization at the genetic level, so sequencing to understand, are they in the smoothing group, the NF2 group, the NF2 in combination with CDK, and or the AKT PIK3 pathway. They undergo treatment with these agents, evaluation for toxicity, and then basically evaluation of radiographic response and progression-free survival, and have the option to stay on the therapy. And so here was this first group that was completed. And this was again reported this year at ASCO. So primary objectives was to look both at activity, 6-month PFS and response rate, and then also highlight toxicity. One thing I wanted just to highlight, what does it take to get in these particular trials? These would be patients who had had an increase in size of measurable progressive lesion by 25% or more, and that had to occur on scans that were occurring within a year of each other. So it had to be a relatively rapid increase in size. And then the measurable disease had to be at least 10 millimeters worth of measurable disease. And I wanted to highlight those two elements for you. Historical benchmarks were used to set the interest level in terms of response rate, and this was from the Cayley et al. Neuro-oncology meta-analysis in 2014, looking again at grade 1 and grade 2 and 3 patients. So I'll briefly highlight what's been found in this first group. Here was the schema and the randomization of both grade 1 recurrent progressives and then grade 2 and 3 recurrent progressives. And you can see a little bit about the patient characteristics here. Average age about 50 for the grade 1s and a bit higher for the grade 2 and 3 patients. A number of them had been on steroids prior to treatment. Most of everyone had had previous surgery. Almost everyone had had, a vast majority had had prior radiation therapy, and a number had also had prior other systemic therapies in these cases. And so here are the curves for both the progression-free and the overall survival. And in the grade 1 patients, the progression-free survival at 6 months was about 83%. For the grade 2 and 3 patients, it was about 33%. And then overall survival, 100%, 91%. And this was compared against the rate of probable of interest in this meta-analysis that I mentioned. Greater than 50% for grade 1 and greater than 35% for grade 2 and 3 as being of interest to proceed to a phase 3 trial. And so it looks like for the NF2 subgroup, that will now proceed along to a phase 3 trial for patients with NF2. And toxicity was tolerated in this series. And then a couple of other things I just want to mention, which is I highlighted that there were some other subgroups, the smoothen subgroup and also the AKT subgroup. And those groups will be essentially reopening here post-COVID and continuing enrollment. So that will occur in the next few weeks, and patients will be able to re-enter into those subgroups and those cohorts while the planning for the NF2 phase 3 is ongoing. So this is, again, a notion that deserves investigation for patients who've had great surgery, but now are faced with the difficult problem of recurrent and progressive disease. And that's our overall schema. You can learn more about these trials at clinicaltrials.gov as well. One harbinger of potential problems is the fact that as we move from grade 1 to grade 2 to 3, we know that genomic complexity increases. So we may find that the most difficult tumors, the ones that would benefit the most, also this issue of single agent therapy is something that comes back to rear its ugly head. So in summary, a new understanding of underlying meningioma genetics and the first trials of specific pathway inhibitors have been initiated. And I want to call out many of those here at my institution who've contributed to this work and some of their efforts. So let me talk a little bit now about the biggest challenge, which is the context, the concept of personalized therapy in a situation of high genomic complexity, such as in the case of GBM. And I really think that we just probably ought to put it out there up front. The single agent personalization in this context is really likely to fail because of that genomic complexity. So we need to be thinking about strategies that get beyond single agent for this type of complex tumor. I'll just highlight an example of this. A few years ago, we built out a CAR T cell that was targeting EGFR-B3 positive tumors. So the antigen is, of course, presented, and this is a typical CAR T construct with a single chain antibody that binds to a signaling moiety and is transduced into its CD8 positive T cell for redirection towards basically cells that express EGFRB3. We now know that great work has been done in the blood cancers to show that this is clinically efficacious in those tumors, and there have been advances in the typical signaling moieties that have been used. This end effector cytotoxic T cells can be engineered genetically, which does open up interesting concepts for brain tumors. We don't have really evidence or FDA approved evidence for use of this strategy in solid tumors, but it's an ongoing area of discussion. And so again, the standard way that T cells are recognizing antigen is in the context of MHC1 binding, a peptide in the peptide cleft, and the CAR T approach is really directly binding antigen. And so this strategy gets away from a glioma, for example, that had downregulated MHC1, and that's the notion. And of course, V3 as a target is an interesting one. It's present in a substantial proportion of tumors. About 35% of GBM patients have this particular antigen. So it's a very reasonable concept to try to go after it with a CAR T approach. And we've continued to develop different CAR T strategies on this. This occurs in the context of immunotherapy and the revolution in immunotherapy for cancer generally. And we know, again, that the blood-borne cancers have really pushed this along. The transduction process has gotten systematized and standardized, and it's relatively straightforward for biopharma to now produce these cells with these modified receptors. This is a little video. I don't know if it'll show particularly well over Zoom, but we'll try it. This is a plate with a variety of U87 EGFRB3 positive cells on the right-hand side and U87 EGFRB3 negative cells on the left-hand side. And as these T cells start to scan the tumor cells, what you observe is that on this side of the plate where there's the cognate receptor on the T cell and the cognate antigen on the tumor cell, the cells are essentially wiped out one by one. And so there's a clearing of these EGFRB3 positive cells in just a very short time. However, here on the left, where you're antigen negative, there's essentially no clearing. The cells are very specific. They're going after only the antigen that's present and the EGFRB3 positive antigen that's present on the right-hand side. So this is really a warning shot over the bow for therapies like this, monovalent CAR T, in the context of a complex tumor. And in fact, this was borne out from the great work that came out of Penn by Don O'Rourke, when they actually did this in patients, and they showed that there's an initial response to the infusion of systemic infusion of CAR T cells, but then in a relatively sort of rapid fashion, there is recurrence of disease. And what is observed in that context is when you look histologically at the untreated patient that was initially EGFRB3 positive, now at recurrence post-CAR T EGFRB3 treatment, you're now EGFRB3 negative. So you've run out your resistance clone in this context. And we could predict this, but we also know that this genetic engineering approach holds promise because there are other things that we can do. Heterogeneity is critical in GBM, and Mario Suva here has been really interested in single-cell RNA-seq. And if you're interested in this, I'd point you to this paper in Cell in August of 2019 from the Suva lab. Mario's a terrific neuropathologist here, and he's shown that GBM really lives in his RNA data in 4 different states, each with different expression programs, and that GBM can morph between these states with therapeutic intervention, making it a very difficult challenge. We have a chief resident here, Brian Choi, who is joining us with faculty, and Brian has really sought to take on this challenge. So one of the things that Brian's been doing is taking standard CAR T and modifying that to try to come up with something new. I'll show you a little bit about his work just because I think it's so interesting. In this context, what Brian is doing is he's created bispecific T-cell engagers, or these are bispecific molecules that bind to an antigen on the directive T-cell, as well as an antigen on the tumor. And bringing those two in proximity, allowing the T-cell to engage the killing process on the target cell. And so here's a conventional CAR that has a single chain antibody targeting an antigen. This would be a bispecific CAR, a double transduction of a T-cell that allows you to go after two antigens. This is what is called a CAR BiTE, or we've renamed this a CAR team. Turns out that BiTE is a word that's already been basically protected from trademarks. So team stands for T-cell engaging antibody molecules. And so this cell produces a CAR, which takes it into proximity in the tumor microenvironment and milieu, but it also secretes a team, or a T-cell engaging antibody molecule that has a bispecific nature to it. And in this particular case, I've drawn out in the schema here, the idea might be that you would have an anti-CD3 to engage the T-cell and an anti-EGFR wild type to engage the more common EGFR wild type amplification that exists in GBM. And what Brian has shown is that if you take this approach, you can get secreted BiTEs to engage now bystanding T cells that are not transduced, they're not specific for the tumor, but they can then cause that tumor microenvironment to become an anti-tumor microenvironment through these secreted molecules. And he's shown efficacy in preclinical models in preparation for a phase 1 study of this approach. And also note that it would be very difficult to give a systemic administration of an anti-EGFR CAR because of the widespread expression of EGFR. However, in this context, you're doing very local expression, and Brian showed that this helps mitigate systemic toxicity. So GBM is complex, but genetic engineering is complex too, and there may be a way to fight fire with some of these engineering approaches. I also note that Brian's taken this one step further, creating a CRISPR-Cas9 strategy to knock out PD-1 on the CAR T surface, rendering it less susceptible to the immunosuppressive microenvironment. And this is kind of what that construct looks like in his recent publication on that. So what about personalization for something that, as neurosurgeons, we do all the time, operating on patients? And we know that there's the proliferation of molecular information now about our patients. We know that this is prognostic, particularly in the context of IDH1 mutation status, showing much improved survival with those patients with mutant tumors. We know that this also predicts response to chemotherapy, and emerging evidence that this predicts response to GTR. And these mutations bear being analyzed in really every patient to understand better their predicted natural course. So how would we improve outcome for patients with gliomas? Part of that's understanding the outcome is related to natural history plus treatment. But if natural history is really dictated by classification, we have to get the classification right to best do that. And of course, WHO 2016 does that to a great degree. Goes beyond the histological diagnosis that we've all relied on for so long. And in this context, molecular biomarker information actually, I think, can be helpful to us even as we're planning surgeries. So let's just talk briefly about a patient like this, a large non-enhancing component and perhaps a small dot of enhancement here. Depending on where the patient's biopsy, that biopsy may come back as a grade 2 tumor, or maybe if we get that enhancing component, we might see grade 3 or grade 4 disease. There are limitations to stereotactic biopsy based on sampling, and there can be divergence between the stereotactic biopsy and the ultimate resection result because of that. We know that in low-grade tumors, IDH1 mutation is very frequently noted, and it's canonical. It occurs at certain hotspots. So if we could understand understand that IDH1 mutation really equals low grade, that might allow us to use that information either peri-procedurally or pre-procedurally to dictate how we might attack that tumor because of a potential differential benefit to better resection in such patients. So a new paradigm, again, molecular groups versus histological groups. Let's maybe skip this slide. So we've all heard the notion, just remove the tumor, resection helps every patient, but we're always balancing differential benefit versus risk. So while it may help an older patient with an IDH wild type tumor a small amount, it may significantly help a younger patient with an IDH1 mutation to really do that aggressive resection and bear out some of that risk of that more aggressive surgical resection. So we might replace the notion of just take it out with take out the right amount based on these data. And again, these are some data just showing survival curves that GTR helps patients of all ages, but the benefit is greatest in younger patients. And similarly, it's greatest in lower grade patients in terms of the effect of GTR. And then Dan Cahill here has really emphasized that in these best prognostic groups, if IDH1 mutation occurs, we see the best result from gross total resection of both contrast and non-contrast enhancing components. So here's an example. This is a patient, 48 years old, is a seizure, biopsy, anaplastic astrocytoma, IDH wild type, within a few months, post-chemo radiation, multifocal enhancement, and GBM. Low survival. Here's another patient, 47 years old, same thing with a seizure, anaplastic astrocytoma, IDH1 mutant, stage resection to get both the enhancing and the non-enhancing component, and now 10 years later or 11 years later, no evidence of disease. So vastly different stories, and maybe different patients in terms of pushing the envelope on the resection. And so this is a summary of how molecular biomarkers might help us. I'm really excited to hear more from our panelists about intraoperative diagnosis as well, because I know we have experts in that. And just want to bring out this concept that mutant IDH1 tumors and wild type IDH1 tumors, while both receive benefit from resection, the benefit is expanded in IDH1 positive tumors. And I'm going to skip this part and then move on. So we had a couple of neurosurgeons who've been really interested in pushing the envelope. How can we figure out earlier in the process if a patient's tumor is IDH1? And Ganesh Shankar has pushed the idea that maybe we could achieve intraoperative IDH1 status or diagnosis. And so what Ganesh has published on is rapid intraoperative molecular characterization of GBM. And the idea would be that a newly identified brain tumor is there, resection occurs, and in the moment, one could actually deliver an anti-IDH1 adjunctive therapy. And he's been working with MIT scientists on polymer-based strategies for this. But a big critical element of this is, can you get the diagnosis quickly? And so he's developed a qPCR assay that can be done in about 30 minutes, which in our hospital is not too dissimilar from the frozen section time, and is able to characterize IDH1 intraprocedurally in a CLIA certified assay. It's a standard PCR approach with some special tricks to improve the annealing of the probes, but this is, again, a rapid approach. And in Ganesh's paper, he highlighted that this could be done in the intraoperative context, and that this correlated directly with the final and ultimate pathological diagnosis in these patients. So again, rapid diagnosis intraprocedurally, and with an eye towards a future IDH1 or other mutation-directed therapy is kind of coming our way. And again, I'd love to see some of the work on Raman spectroscopy and other techniques that can maybe be much faster than this. So I won't touch on this, but this is the team that's been working on that. So in this last little section, I just want to highlight a little bit of work about the liquid biopsy approach. And we have a substantial team that's interested in liquid biopsy. The idea is, could we know molecular status? Could we even diagnose a tumor before touching the tissue based on an analysis of blood or CSF? And this is a relatively long story, and I won't be able to tell all of this story, but it starts with our interest in about 12 years ago in extracellular vesicles and understanding that tumor cells, particularly GBM cells, are releasing these vesicles into the plasma. And we've now come to learn that GBM cells also release entire cells, so circulating tumor cells. They release a cell-free fraction, including DNA and other proteins, and then also this exosome or extracellular vesicle fraction that encapsulates some of these macromolecules. These can all be assayed in different ways, these molecules. And this is an up-close view of them on microscopy. They're less than 100 nanometers in size, but they do encapsulate cellular RNA and associated proteins. So these are released, and this is a schematic that shows this. They're formed in the microvesicular body. They get released into the intercellular space, and they can be taken up by target cells and influence the microenvironment. And there's a large literature on that. But the main messages that I want to highlight for you, this is really a new way for cells to communicate, or a newly conceptualized way that cells communicate with each other, and that during this communication, we can sample these vesicles and assay them. And this can be done at the protein level in terms of glioma detection. This is a paper in Nature Medicine a few years ago where we highlighted that you could couple these to magnetic nanoparticles and capture them and then assay them. They reflect the cell of origin, so the vesicles themselves are reflective of the tumor in terms of the protein characterization. In this study, looking at 24 patients with GBM versus 8 normals, there was a nice ROC for distinguishing the GBM patients from the normals, and that was of note. And this was a set of sampling of vesicles with these associated proteins on their surface. We can also detect mRNA and get a similar distinction of the GBM patients versus the controls. And then lastly, you can do targeted mRNA capture such as MT mRNA and look at therapeutic response. These are all still preclinical and being evaluated. And one of the questions that we've had is whether this could be done to really help us diagnose or predict therapeutic response or monitor therapeutic response in patients. And so a first look that we did in collaboration with the team at Miami, and Dr. Komatar was a key co-author in this paper, was to show that in CSF, they're abundant, and we can detect the same mutation that's in the tumor at about a 50% sensitivity. And we thought that was actually a good starting point. It raises the concept that an LP could actually help us diagnose a tumor that was perhaps in a difficult location. And we published this a couple of years ago in Neuro-Oncology. I'm going to skip past this. We've also looked at CSF in terms of IDH1 and have similar results in terms of sensitivity. So for us, the clinical conception is, could this help us with a difficult to biopsy lesion or therapeutic monitoring of a biologic or viral or chemotherapy? There's a challenge because vesicles are released from every tissue. So one of the challenges that we've taken on is try to parse out the tumor-specific vesicles. We've done this in collaboration with some of the companies that are working with fluorescent detection of tumors, and this includes the 5-ALA story. And so we've shown here, and I'll just highlight that fluorescent positive vesicles are released from 5-ALA treated patients, raising the notion of specifically sampling those vesicles. So can this scale to these questions, and can we actually answer this? In my last moment, I'll just highlight this one exciting work that we have out for review right now, and that is the detection of TERT promoter mutations in plasma. Turns out that most GBMs have TERT promoter mutations, about 80%. They're also seen in grade 2 and 3 tumors. This is very predictive of survival in terms of, in combination with understanding IDH1 status. We've developed a liquid biopsy for TERT promoter in cell-free DNA. And this has always been a challenge because historically brain tumors were not thought to be accessible via cell-free DNA. And in this particular PCR-based assay, Kaushik Muradlan in our lab has highlighted that using some modifications to the PCR step itself and also the sampling step, we're able to detect very low levels of circulating tumor DNA, consistent with the type of levels that you'd see in brain tumors. Less than a few percent has been reported previously because of this challenge of the blood-brain barrier. But in this assay, we've just recently completed a study of about 157 patients. 122 of them were blind and analyzed in a blinded fashion. And we had about an 80% sensitivity in the blood of detecting TERT promoter mutations and a specificity of 90% plus. So where I see this going is therapeutic monitoring of disease burden in patients in terms of active disease. And we have a few patients that we've analyzed in longitudinal fashion and seen TERT float with disease burden. And then also the concept that in some cases, in combination with radiographic imaging, we would be able to diagnose that patient pre-procedure, pre-touching the tissue. So that's a whirlwind, perhaps somewhat exhaustive tour of personalized medicine in brain tumors. And I'm going to pause there and just open it up to questions and hope you've gained a little bit from this conversation.
No, thank you so much, Dr. Carter. I mean, that was a fantastic talk. And, you know, it's just fascinating on how much of that's really just been the last 5 or 10 years. And before that, really, there's not that much. And we're really hoping that this will continue and give us more opportunities for targeted therapies. One of the questions that I had was, you know, as we start for the craniopharyngiomas and meningiomas, as we start to find these occasionally really effective therapies like the BRAF, how do you then go as a surgeon and start deciding as to when to use them? Are they neoadjuvant or post-adjuvant? You know, sometimes patients present with symptoms that are pretty subtle, headaches or questionable, you know, numbness and whatnot. And are these therapies, do you think, that we'll eventually be using pre-surgical to see if they work before actually knowing?
That's a great question, Mike. And my personal belief is that as particularly these first alliance trials get published, we'll start to have the confidence that they're safe to use in the neoadjuvant setting. And I could definitely see, you know, that craniopharyngioma that extends superiorly and is really involved with the hypothalamus. That might be a set of patients that we start to say, well, you know what, let's go neoadjuvant for a period of time, see if we can get that ready for a definitive surgical procedure that's safer and a little easier on the patient. So I do think that would be the dream. The question would be, you know, again, what do we see as these results come out? But that's really, I think, a potential opportunity.
Yeah. One of the questions too is looking back. You know, there's been, I always like to say, there's been like over 1,000 clinical trials on glioblastoma to date, right? And so far, we've had like 3 that have been positive. Looking back on those, so few of them talk about everything you just mentioned, profiling and the subtypes and the alterations. Is there any that come to mind that you wish would have been done over, but yet kind of looked at kind of the molecular abilities that we have today with you know, the subtyping and the stratifications of all the kinds and with maybe some promise?
Yeah, you know, I think it's a great question. One of the things I think, Mike, we all would wish for is better tissue sampling post-treatment and really understanding, are we actually having an effect at the molecular level? And there may be techniques that we can do, but even to get into the culture of saying that it's so critical to understand for a given patient that we have additional information, I'm hopeful that at the intersection, I mean, obviously tissue analysis is gold standard, but I'm hoping that at the intersection of tissue analysis and correlatives with liquid biopsy, we could at least get a flavor early on of the efficacy of a therapy and perhaps start to do trials that allow us to say, you know, fail fast and move on to a different approach for a given patient in combination with the stratification. So I guess I don't know that I would go back and specifically redo those trials, but I think on a go forward basis, we could plan trials that helped us answer some of these questions. Yeah.
You know, that gets to something that I think about all the time. You know, I read The Emperor of All Maladies, and you read about how childhood cancer, they would give patients 5 drugs, and you alluded to this in your talk. And they, you know, it wasn't targeted in any way. It was just 5 massive, you know, bombs basically. And but they did well. They, you know, they treated the kids and they recovered, and due to the resilience of children and whatnot. What are the limitations to proceeding with multiple drugs, you know, targeted drugs at the same time that really kind of attack, you know, multiple areas of GBM progression in our research?
Yeah, it's so interesting. I sit on study section, Randy, and the vast majority of trials that I see coming through are really single agent trials. And if you think about it, you know, in a given investigator, they have a relationship with one pharma company, but the moment that you say, oh, I want to do your trial in combination with another company's agent, it just falls apart, right?
Yeah.
I think though, hopefully over time, if we start to say to companies, you know what, your agent, I didn't show the data, but we have a kinase inhibitor trial where we showed with exosomes, we were able to really tease out the patients that were going to have a response clinically through markers. And maybe that combination of saying, hey, come and join with us, let us do a multi-patient trial. We're only going to use your drug on the most appropriate patients. But then building in an insistence that, hey, we have to have coming together, particularly on the pharma level of multiple agents. But I think it's a real problem. And I always feel badly when I see a trial that's proposing just a single agent attack in GBM, because I just feel like it's going through time and money.
Yeah.
Agree.
Yeah.
Okay, let's get to our cases then. Maybe Dan, do you want to start us off?
Okay. Okay,
Great,
so
that's good, thanks.
can you hear me okay?
Yeah.
Yeah, so this is a hybrid case presentation and a little bit about some of the technologies that Dr. Carter alluded to. I want to start off by thanking University of Miami, Mike in particular, and the other panelists, and everyone except for Dr. Carter, who I have to follow. I mean, following Dr. Carter is pretty tough to act to follow. So
Thanks for going first, bud.
happy to be here. So first, I'll start with disclosures. I'm going to be talking about some technology I'm developing in collaboration with industry, and it's important to acknowledge these conflicts of interest. And first, we'll dive right into a case, a 76-year-old gentleman I recently treated with this following scan here. As the radiologist said, 2 large, complex heterogeneous masses, intraaxial with hemorrhagic foci. And the radiologists conclude that these are most suspicious for metastases. I think I'll just pause there and get Dr. Carter's take on this case and the other panelists to see what people think about it.
Yeah, thanks, Dan. And it was fun to hear the sirens in the background. I felt like I was in New York for just a moment there. but no, this is obviously a really tough case. You know, the heterogeneity of enhancement and the associated vasogenic edema. You know, I'm suspicious of potentially multifocal malignant astrocytic disease, but obviously Mets are in the differential as well, and I'm sure that our panelists have other thoughts too.
I think these ones are hard. I think with that amount of vasogenic edema, it's so hard to counsel the patient on, you know, you're going to have Mets treated, systemic disease control is good, you're going to have a normal life expectancy or a decent one, or you have multifocal GBM and, you know, 11 months to live. So we would probably do just a needle biopsy, probably on that right anterior lesion, just to get an idea of what to counsel the family on. Keep them in-house and then counsel, get the path back, and then go for a full resection if there were bilateral mets.
Yeah, I think that I agree with you, Vijay. Obviously, the conversations are very, very different. But I think, and I hate stealing Mike's thunder, but I think actually Miami just published data about what to do in these situations, right? That's pretty convincing. And I think in this case, if you can safely do, it depends what the symptoms are, obviously depends what the systemic workup is, but removing either the larger or the more symptomatic lesion, trying to preserve quality of life here, there is, a potential benefit that at least anecdotally or, with some support. So but definitely a tough case and definitely a long conversation.
Yeah, thanks, Randy. I mean, we just looked at our multifocal glioblastoma series, as he's talking about, and in cases where we felt that you could still get a meaningful resection just because they're multifocal, doesn't mean you shouldn't offer surgery. I mean, obviously, this case it's very challenging, like you said. It's very equal kind of volumes almost. I mean, obviously the right's a little bit bigger, but the left is very close to speech. But if the left one was smaller, and even if you knew it was glioblastoma, currently we found that if you could, the larger lesion is 80% or more, still approaching it as a glioma resection and removing it has benefit to the patient.
Yeah, so excellent thoughts. I'll come back to what we did in a second. Just going to advance to the next slide here. So when we're thinking about a lesion like this in the OR, I took this idea of a basic box step from Dr. Lawton, one of the talks that he was giving about how he approaches aneurysms. And our first goal when we take a patient like this to the OR, whether we're doing a biopsy or resection, is to verify that we have lesional tissue. Once we know we have lesional tissue, then the question is it neoplastic or is it non-neoplastic? Because that's always, non-neoplastic processes are always part of the differential. If it's not, if it's an inflammatory condition, an infection, a stroke, or something else, then medical treatment is most appropriate. If it is neoplastic, then we have to think about, well, is it lymphoma or germinoma or some other type of neoplasm that is best treated without surgery? So if it turns out to be lymphoma or germinoma, the operation is over and the patient opts for medical treatment. If it's not, then the question is this something that's arising from the brain or something that has spread to the brain? If it's not intrinsic to the brain, we're thinking most likely metastasis or meningioma. If it is, then the question is this high grade or low grade? We usually have some suspicion, but in a lot of cases, like a couple of the cases that Dr. Carter showed, it's not immediately obvious which is which. If it's high grade, we're thinking glioblastoma, anaplastic gliomas, or PNET. If it's low grade, we're thinking about whether it's diffuse or whether it's focal. If it's diffuse, it's going to be astrocytoma or oligodendroglioma, or something very rare, but usually they fit into those categories. If it's focal, it's going to be pilocytic ganglioma, or something, there are numerous, focal gliomas that are much less commonly encountered. But this is the framework that we have to have in our minds generally when we're taking a patient to the OR. And we rely very heavily on our pathologists to allow us access to this decision tree, because as surgeons, we see tissue that looks kind of normal, we see tissue that looks maybe abnormal on a macroscopic scale, but this entire pathway is something that occurs on a microscopic scale. So rather unnaturally, going back to the time of Cushing, there's been this barrier between neurosurgeons and their pathology lab. And although Cushing argued for the importance of understanding diagnosis on a microscopic scale, because that diagnosis happens in a way that's physically separated from the OR, it's hard for us to access this. So my focus has been essentially in figuring out a way to eliminate that barrier. And we've done this through this tool that is called stimulated Raman histology that we developed out of a basement lab in Harvard, and have now done, personally, I've done over 1,500 cases with the technology, and I'm pleased to report that an increasing number of centers across the country have adopted this, and we're well over 2,000 cases done with this technology which you can read more about. But what it allows us to do in the context of the case that I mentioned is to eliminate the guesswork about the diagnosis and to be able to nail that diagnosis within minutes in the operating room. So in this case, when we took this tissue, took a little piece of the left frontal tissue, we put it into our imager in the operating room. And what we saw was tissue that demonstrated evidence of viable tissue in some areas, necrosis in others, glomerular microvascular proliferation, cellular pleomorphism, mitotic figures, tumor cells that had long glial processes. And we knew right away, this is glioblastoma, this is high-grade glioma. So, you know, the box step is straightforward for this. We know maximal safe resection is the key here. And we also know that in the context of multifocal GBM in a 76-year-old, we have to really think about what the implications of our surgery are going to be on the little time that this gentleman likely has left. So what the technology allows us to do, and what I think is cool and personalized about the technology, is that we can understand exactly what the pathologic process is that we're dealing with within minutes in the OR. That being said, as neurosurgeons, our training is primarily surgical, and it's a pretty big idea to bite off all of neuropathology as well, incorporate that into our practice. So one of the efforts in our lab has been to automate the process of diagnosis. And the images we acquire with SRH are natively digital, and they're very well accustomed to being analyzed with the help of brilliant individuals like Todd Holland, who you see here, to apply techniques of artificial intelligence and specifically image analysis to be able to predict diagnosis very rapidly. And so we have established a pipeline and validated that pipeline in collaboration with Dr. Ivan and his group at Miami that allows us to achieve multi-class diagnosis. We can differentiate among the 10 most common types of brain tumors from tissue to diagnosis within 2.5 minutes. And we validated this in a prospective trial of 278 patients across 3 institutions, including Miami, Columbia, and Michigan, and found that the automated pathway was 94.6% accurate, while the conventional pathway where pathologists were reading H&E slides was 93.9% accurate. Interestingly, there were no overlapping errors, which creates the possibility of developing this as a tool for pathologists to ensure that errors are not being made. At this point, though, it is important to note that what Dr. Carter was bringing up about the importance of molecular diagnosis really has implications in the operating room too. And the next generation, as he alluded to, is to not just be thinking about the morphologic diagnoses in our box step, but to be taking a more granular and more accurate, really, approach to being able to understand, okay, is this an MGMT mutant glioblastoma, or is it going to be, I should say, is it methylated or unmethylated? Is this an EGFR mutant GBM? If it's a low grade, is there an IDH mutation present? Is it 1p19q or ATRX? What's the TERT promoter status? If it turns out to be a circumscribed glioma like pilocytic or ependymoma, does it have a BRAF V600E mutation? And so what we've been able to do is apply some of the same types of AI technologies to be able to make that bedside AI-based molecular classification of reality. And this is really a work in progress and being driven by Dr. Holland, who was my postdoc and is now starting his faculty career at Michigan in the coming year. But what we've been able to see is that we can take the morphologic cues that we see in the tissue in the operating room and with greater than 90% accuracy predict the genetics. And this really does create the possibility of a very streamlined pathway from tissue to molecular diagnosis within minutes in the OR, and creates the possibility of doing personalized medicine in a way that we hadn't ever conceived of before we had access to that data on that time scale. So this is kind of my take on where personalized diagnosis is going specifically in brain tumor surgery and glioma surgery. And I want to acknowledge many individuals, a few of which are listed here, who have helped out incredibly in the development of this work.
Thanks, Dan.
Dan, I just think your work is so terrific here, and honestly, it's one of the most exciting things I've seen in a long time in terms of changing the dynamic in the operating room environment. I had two questions. It seems like obviously you must have immediate applications as it relates to sampling strategy. You know, you sample and then you're not quite happy with the sample, and then you might use this information to quickly resample. So that's one concept. And then I guess the other question I'm interested to hear, and I think perhaps broadly the participants in the audience, tell us a little bit about pathology and your relationship with pathology and the political side of working this.
Yeah, so great questions. So probably the application in which the technology is most useful is the one that you mentioned, verifying that what you're sampling will turn out to be diagnostic in downstream molecular analysis. And making sure that as neurosurgeons, we're not wasting time sending tissue that's not going to be diagnostic. We're not sending that necrotic material from the center of the tumor. We're actually sending viable tumor to pathology. So we found that to be incredibly useful. And I won't send something to pathology unless I've verified that it's diagnostic tissue. So that's streamlined things quite substantially. And frankly, I don't send frozen sections anymore because we have this pathway integrated into our health system and a relationship with pathology that allows us to work with them in a collaborative fashion. And sometimes when I present this idea that neurosurgeons will have access to pathology data, people are like, well, aren't the pathologists concerned that we're going to be taking their jobs, or is AI going to be taking their jobs or something like that? But what the pathologists grow to realize is that the technology benefits them directly. First of all, when we do send them tissue, it's tissue that will be diagnostic. And second of all, they've found that they can actually make diagnoses based on the SRH images that we get in the operating room. So our images are directly transmitted to the laptop or desktop computer at their desk, so they don't have to get out of their chair to be able to make the call. And one of our neuropathologists, Matthias Nuderl, who's really been progressive on this, prefers that I don't send frozen at this point, and just we do the SRH, and he's happy making a call based on that. And of course there are exceptions, and there are limitations to any approach and a new approach like this. And there are going to be certain things where we're just not able to see the information that we need to. And this shouldn't be thought of as a technology that would replace frozen section. It's simply complementary. And there's going to be a learning process for neurosurgeons, and there's a learning process for pathologists. But when we work with them in a collaborative way, the integration of the technology seems to be smooth. And I've done that at 2 institutions, so I think it's possible to replicate it.
Great.
Brilliant. Thanks so much, Dan. Who wants to go next, Vijay or Randy?
Very cool. Vijay, do you want to jump in?
Sure, be happy to. Mike, can you see that okay?
Yeah, looks good. Thanks.
Perfect. So, you know, thanks to Mike and the whole Miami team. This is outstanding what you guys have done. Thanks, Dr. Carter and Dr. Oranger and Dr. D'Amico. Admittedly, my talk is on personalized medicine. Most of my practice is actually in the field of skull base. It's about 60% endoscopic and 40% open. But I think we're a bit behind the malignant cancer field. And I think there's been so much advance over the last 10 to 15 years. And we're just playing catch up here. And the two things that we've been working on here at Einstein are really transcriptomic differences in high-grade gliomas. And the thought here is that most people, when they look at high-grade gliomas, group grade 2 and grade 3 meningiomas into the same group. So when I first started here, we sort of made this a focus, and we found that the grade 2 patients really had variable outcomes. They all recurred, but some had very quick recurrence and some had quite late recurrences. And so we really started to investigate why that is. And we thought, you know, it may not be fair to group those patients into the grade 3 group. And so we found a few possible culprits in terms of specific genetic alterations. And what we've been doing is analyzing those. And so we have found, at least anecdotally, that the ones we're looking at have an unfavorable prognosis clinically. So we've sent our first sort of 27 patients from the grade 2s, but I think the most important thing, I think it's appropriate after Dr. Oranger's talked, we went back and saw some of the path, and some of the path was incorrect, actually. So some of the bad acting grade 2s in retrospect were actually grade 3s. So we filtered based off of that, clarified that, and then moved on to fresh samples post our brain tumor bank. But just a couple of slides on the project that we're also working on concurrently, the expression of co-inhibitory molecules. So just as the revolution for immune checkpoint inhibition has really changed the overall survival for lung cancer patients, I think there's a real role for immune checkpoint inhibitors in our field for supracellular lesions. And I think that this kind of shows an example. It's a case we did recently, and we of course did it through a combined approach. I think it just would be tough for us to reach past elevated carotid terminus, and so we did it through a combined approach. But I think this sort of speaks to this sort of technology. And so we collaborated with Dr. Zhang's lab here at Einstein. He did his postdoc on the West Coast with Dr. Allison. So a lot of his postdoc work went towards the Nobel Prize in 2018. And when he came to Einstein, he was very interested in looking at these unique immune checkpoint inhibitors that he had discovered in his lab and their role in malignant brain cancer. And it just took a very little bit of convincing for him to start looking at these in benign disease and skull-based tumors. And so we were really interested in this B7H4 transmembrane protein. And so it binds actually an unknown receptor on activated T cells and really inhibits their function. And we found in sort of our early work that they're implicated in pituitary adenomas. And I think that this plays a role when you have NOSP3A, 3B, and 4s. So essentially when you have extension, we found intraoperatively a lot of these pre-op images show bowing of the cavernous sinus, not so much encasement of the carotid. So if you decompress, you can reach around and get a gross total. But when you actually have 270 and 360 encasement of these arteries, it's very difficult for us, for far extension lateral in the temporal lobe, to resect these on patients without a combined approach. And so to Mike's point, when we would use something like this, if B7H4 actually does turn out to be implicated, the way we see these clinically is just as radiation has been used to shrink esthesioneuroblastoma before resection to bring in negative margins and resect those. This is what we would see eventually for this sort of discovery, that these patients with encasement or 270-degree encompassing of the carotid arteries, where they may need a combined approach, could be treated preoperatively, shrink the tumor, so a single transnasal approach could resect. And so we've just started sending our initial samples, testing intraoperatively to check for an assay we developed in the lab for the B7H family, specifically for supracellular tumors. And what's interesting is we sort of set out to do primarily pituitary adenomas, but we've had a variety of supracellular pathology, including metastasis and things like that. So the data is still quite early, but we're hoping to get an idea of the role the B7H4 family plays. And this is a case we have coming up, but I think that this would be a perfect example. And with this much lateral extension to the carotid, we're planning a combined approach on this patient, but this would be a perfect example where eventually, if we had personalized medicine for skull-based tumors, we could preoperatively treat these patients, as Mike had mentioned, to shrink this down where it would just necessitate a transnasal approach to potentially resect those tumors. So I think we're a bit behind sort of the malignant cancer realm, but I think a couple of those recent cases show the power in benign skull-based disease as well.
BJ, that's terrific. I didn't mention in my talk, but one of the things that Priscilla is working on is a Pembro trial in meningioma, and I think this would be a good example of trying to work out the concepts that you've elucidated and neoadjuvant therapy in certain situations. The tumors that you're showing would absolutely, I think, benefit from that if that shows efficacy. So
yeah, that sounds great. It's a lot of that work from MGH and Ian Dunn in Toronto, and it's really laid the groundwork. So yeah, hopefully we find something.
Great work, Vijay. Yeah, I know Gabe Zada also is looking a lot at the PD-1 and pituitary as well, and I think that's going to be super helpful in these very, very challenging cases like the one you're showing. So good luck in that case.
Absolutely.
Whole day's work. Okay, Randy.
Yeah, I'll share real quick. I think Vijay, you got to stop sharing first. Yeah. So truthfully, the reason I'm happy to go last is because Dr. Carter already talked about the majority of what I was going to talk about, which is fortunate. But basically, this is a 23-year-old with recurrent pilocytic astrocytoma. He had had 2 previous interventions, and obviously a difficult place and a young person. But the key was that we had the BRAF V600E mutation. And so, you talked already about this, and I think, just to kind of harp on a few things, even though these aren't, molecularly complex or genetically complex lesions, the interesting thing here is that this mutation predicts therapy response, regardless of your histology. And so it really, I think, highlights, and you mentioning as well, especially starting your talk off with it, the necessity of looking at these things now. This is modern, tumor medicine. This is modern neuro-oncology. We have to characterize these tumors, and we have to be, goal-directed and patient-oriented with our treatment. And so again, the majority of this kind of rehashes what you talked about, but let me just go back over here. It's also important to realize that, this isn't just a papillary craniopharyngioma mutation. And so the case I showed was a pilocytic astrocytoma, and granted, it's only 9% of these cases, but again, reflecting the importance of considering everything and doing these assays and panels to really characterize, what we're treating. And so we used combination therapy, dabrafenib and trametinib, which we know is under phase 2 trial evaluation. And this was our response, and it's a complete clinical improvement based on looking at symptoms, and then a partial radiographic improvement, but still a 92% reduction in tumor volume, and still going now for 30 months, which is incredible. And just again, the power of what this holds if the future of neuro-oncology is incredible. The one thing I always think about, and it's unrelated to this, but more related to the stuff that I'm more interested in, is not every drug gets to the brain, and we know that this is a hindrance, and so I tend to think about these things not so much of extent of resection anymore, but extent of treatment, and that's kind of the future of what we have to do. And so, how are we going to how do we get the drugs that we need, or the therapies that we need, the nanoparticles that we need, whatever it is, into the brain? And so I've looked at the past, and this is just a figure from a paper that I have out, where it's convection enhanced delivery. Right now at Lennox, we focus on intraarterial delivery. But I'm curious, Dr. Carter, have you guys looked at this, and is this a consideration when you guys are looking at your novel therapeutics, or what techniques you guys have used to look at this?
Yeah, we've been interested in CED and participated in some of the earlier trials on CED. But I think, Randy, you're bringing us to a really important point, which is maybe there could be a shift in the standard approaches to allow for repeated, again, sampling to know, hey, are those agents actually getting in? Are we getting histological biomarkers, or perhaps Raman biomarkers of actual efficacy and an alteration? So here's an idea that we could put out there. Let's say that after a GBM resection, it became some form of a standard under protocol to put in, an Ommaya for CSF sampling, and be able to sample serially over time in a patient that was going to be participating in a certain targeted therapy, and really assess. The CSF is a little better for the liquid biopsy, in my opinion, present day. So that's one concept. Maybe blood as well. We're a little farther behind on blood. Tissue would be important, having protocols. So there's a U19 out from the NIH, which is a big consortium grant, and they want to look at small molecule inhibitors. I hope that some of the projects in that U19 do repeated sampling of the tissue.
Yeah, that's huge. We did that actually. We're putting it together now, but before I left residency, we were doing repeat sampling on our convection patients with Jeff Bruce at Columbia, And we have some of that data about post-treatment. Now, the issue is what drug you treat with, right? And how every individual drug is going to change this. So I think what you're saying is absolutely critical. You need to follow these tumors. They're, you know, they're heterogeneous. That's just by nature of how they work. And every cell is going to change in a different way. And we need to be able to, you know, trend that and monitor it and anticipate, you know, with our treatment, what's going to happen next, so we can, you know, be there to stop it. And
Yeah.
Dan stuff's always super impressive. I love it.
One other thing I'll highlight, Randy, is, you know, you highlighted the fact that certain alterations might only be present in 6, 8, 9% of patients, but wow, it can be so powerful in those patients. And I think as we start to pick away at those percentages and have a portfolio of agents for each mutation, it gives us an opportunity.
Yeah. Then you're just limited by the study design. That's it. Trying to figure it out.
Yeah, and I think that's a great case example, Randy. I mean, I had one too, but I saw your slides and it was very similar. But you know, these deep thalamic or interventricular low grades, where the patient comes in with a headache and maybe some hydrocephalus, this ability to biopsy and maybe stop and then do precision medicine and decide, you know, do you want to do this radical resection in a high risk area, or if there is a BRAF mutation or additional mutations that we will find, is it the right time to try that first and then to shrink the tumor or not? And time will tell, but I think that's the way we're moving. But I just want to thank everybody. I mean, those were really phenomenal talks by everybody tonight, especially Dr. Carter. Thank you so much. I think the future is bright in brain tumors, and it's thanks to many of you who are here tonight. So thank you again.
Thanks, Mike. Thanks, Dr. Carter.
Thank you, Dr. Carter.
Great session. Thanks everyone for bearing with us. So, good night.
Take